Hello and welcome to a presentation with our friends and colleagues at JRF Ortho. My name is Robert Benedict, a Senior Product Manager with Arthrex on the Biologics team, and I'm here with Christian Beziner, who's the Director of Medical Education at JRF. And today he's going to be sharing the outcomes and post-op protocols with fresh osteochondral allografts. Christian, thanks so much for joining us, and take it away.
Thanks, Robert. Pleasure to be here. Thank you for the opportunity. And yeah, the goal for the next few minutes will just be to give everyone here a bit of an update in terms of what's happening with literature and publications around osteochondral allografts, specifically a bit of an overview of outcomes and what surgeons are talking about when it comes to post-op and rehab protocols with these grafts. So we won't go through the literature and publications in great detail. I have a list here. This bibliography is on file with JRF. Please feel free to reach out to us at any time if you'd like to get a more detailed list. But the takeaway here from a literature standpoint is that even though osteochondral allografting is a concept, at least, that goes back at least 100 years, it is still a very, very timely and very, very hot topic for research. So just in the last 15 months or so, going back to the beginning of 2019, there have been 61 publications specifically on the topic of OCA grafts. And those, run the gamut of different aims and focus on the papers in terms of basic science, so looking at storage methodologies and improving viability of the grafts, imaging studies, outcomes, surgical techniques, starting to take a look at a lot of OCA combined with osteotomy or ligament reconstructions, or even adding augmentive or adjunctive therapies like BMA or PRP or something like that to improve the healing of these grafts. Of course, return to work, return to sport, and then there's enough literature there that there are multiple systematic and technique reviews out there looking at larger bodies of literature as well. In terms of what JRF is supporting, so we make it a focus of ours to try to support research and literature publication within our space, our niche, as much as possible. So we have some forthcoming publications that will speak to MOCA consensus statements. I'll talk a bit more in just a moment about who MOCA is. But we've got a couple of different consensus statement papers that are working their way through for publication on OCA guidance in general, and then specific to the patellofemoral joint. We have some papers forthcoming on reimbursement, which are very, very interesting, taking a look at audits of payer policies, how we can potentially work with the surgical community to bring those perhaps a little bit more in line with the clinical view of the use of these grafts. And then even though this talk is focused on osteochondral allografts, we do have some papers coming out having to do with meniscus transplant sizing and donor and patient matches as well. From that body of 61 papers in the last 15 months, here are just 3 that I've highlighted very quickly that have to do with looking at longer-term surgical outcomes in different populations with osteochondral allografts, specifically to the knee in this case. From a clinical outcomes standpoint, again, you talk about that many papers and really a history of probably 25 or 30 years with some surgeons in their series. There's a plenty of information out there about surgical outcomes in general. It's very difficult to aggregate that information. Overall, as with any surgery, appropriate indications, appropriate patient selection have a lot to do with the ultimate success. So as those concepts have evolved over time and surgeons now better understand who these grafts, in which patients these grafts work best, you see these overall outcomes, being very, very successul, and graft survivorship lasting, 10 years plus in many, many cases. In an attempt to sort of aggregate that a little bit, just throw up this chart here. This data comes courtesy of Dr. Bugbee when he presented that the diagnosis for the patients has a lot to do with the ultimate outcome and ultimate success. But if you look at the failure rates, the IKDC scores, and the overall patient satisfaction, these scores are really tremendous overall. But you look at certain subsets of these groups: OCD lesions, traumatic chondral injuries. The success of OCA grafting is really as successful as probably any other procedure in the orthopedic space. And so if you sort of brought that data together and you could, come up with your home run patient, who do these grafts really have the most positive impact on? This again was Dr. Bugby's comment on the perfect patient when it comes to a knee graft. Younger in age, OCD or traumatic lesions on the condyles or trochlea. And again, talking about relatively large lesions here in these patients. But if you can bring your patient population down to that type of group, you're talking about extremely low failure rates, low reoperation rates, graft survivorship that's nearly 100% at 10 years, and very high satisfaction and IKDC improvement scores. So really, pretty impressive, again, if these grafts are chosen for the appropriate patient. I mentioned a couple of minutes ago the MOCA Group with some forthcoming papers on consensus statements. The MOCA Group, it stands for the Metrics of Osteochondral Allografts. This is a group of select thought leaders and surgeons that we helped put together a couple of years ago, really with the goal of sharing knowledge that exists about osteochondral allografting, and then pushing the science forward, asking the questions that still need to be asked, and then going and studying those questions. Here's a list of the surgeons involved in that group, and again, some very big names in terms of thought leaders in the sports medicine and orthopedic space. And they are really pioneers in many cases when it comes to osteochondral allografts. When it comes specifically to post-op and rehab, we asked this MOCA group then to develop some consensus statements around the best way to treat these patients after the surgery has occurred. And as you might imagine, there's a fair amount of variability even within this group of experts. And so in terms of weight-bearing post-op, the consensus statement was that some initial period of partial weight bearing is an appropriate post-op protocol. Weight bearing as tolerated in conjunction with an extension brace is an appropriate protocol for patellar or trochlear reconstructions. In terms of return to sport, return to work, return to activities, the consensus was that there's not only a time component, but it should also involve functional endpoints in terms of their physical therapy and their functional recovery. And that this MOCA group would continue to work with evidence-based medicine and insurance medical policies for looking at best rehab and post-op protocols, specifically for patellofemoral lesions. And one paper that I just wanted to highlight quickly in this area came from Dennis Crawford. And this was interesting from the standpoint that this is not his own personal post-op protocol, but this was a survey of orthopedic surgeons, 76 responses, to this survey. And these are surgeons who had performed at least one osteochondral allograft in the prior year. And you see that there's quite a bit of variability here. So the post-op ranges, the protocols range from weight bearing as tolerated all the way to non-weight bearing or partial weight bearing up to 12 weeks. The surgeons, interestingly, the surgeons who perform fewer of these cases, this makes logical sense, but they tend to be a bit more restrictive in their post-op protocols, and as they become higher volume in this area, they tend to get less restrictive. Another way of looking at that is that they become slightly more aggressive with rehabbing these patients, again, as they develop a comfort level around what to expect. And for most surgeons, return to full activity, return to sport happens at somewhere around 26 weeks, although a minority of the surgeons, around a quarter of them who responded, did start to lift restrictions on patients earlier than that at about 16 weeks. So that's a little bit of a highlight. It's a high-level overview of where the literature stands and what surgeons are talking about from an outcomes and post-op rehab standpoint. So thank you again for the opportunity, Robert.
Christian, that was a great presentation. Thank you so much. You know, the feedback and the role that JRF has played in developing the MOCA Group is tremendous. The output that you and the group have committed to, and we just wanted to thank you for that. That's so appreciated in the community and certainly by our industry. You mentioned kind of the storied success of fresh grafts and the role that these tissue play in helping patients do well in their post-operative care and following these traumatic or other type of injuries. You know, where do you see fresh grafts going though in the future? We have a lot of good data in the knee. There's some new data coming out for other joints, but what do you see as being the prominent new indication that we're focused on in the future?
It's a great question. The majority of the science, the majority of the clinical experience has been in the knee. And even in that space, there's still a lot of buzz and a lot of discussion about, you know, adding biologic adjuncts to the grafts and things like that to even further improve healing and clinical outcomes. But I think you're right. The technique, the instrumentation, largely driven by Arthrex. You know, all of these, they've gotten better. They've made it more reproducible for surgeons to be able to approach this grafting concept in the knee. And so now you just extrapolate that to other joints. So we're seeing more and more interest in treating lesions really almost anywhere you see an articular, you know, surface. And so there's growing interest in the shoulder. Of those 61 publications, over 10% of those had to do with foot and ankle. We see publications and clinical interest in grafts for elbows, hip, even custom graft orders related to trauma for fingers and toes. And so we really try to be able to provide any surface that has cartilage on it if the surgeon feels like that's the appropriate intervention for the patient. And the science and the instrumentation support are really moving in the direction to be able to do that.
That's great, and thank you again for your time. Great presentation. We truly appreciate your time and appreciate you joining us today.
Thank you.